Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Scott L. Friedman, MD. He's the Dean for Therapeutic Discovery, the Fishberg Professor of Medicine, Professor of Pharmacologic Sciences, the Chief in the Division of Liver Diseases. And we're going to be talking about his research and the things he's working on and how that's relevant to today. And he's part of the Icahn School of Medicine at Mount Sinai. So, Scott, thanks for coming.
My pleasure, Richard. Great to be here.
Yeah, so are you more of a physician or physician scientist, or are you teaching into peer research? Like, what are your activities these days?
I would qualify my skills as mostly physician scientist now. So I spent most of my career seeing patients and doing lab research. In the last 5 years or so, my administrative roles enlarged, and so I gave up patient care. But I'm still deeply involved in designing clinical trials, overseeing a clinical program. It's something that doesn't leave you even if you're not at the bedside.
Okay. Then what's some of the current trials that you're shepherding through the process?
Well, it would be worth backing up a little bit, and let me just give you a bit of context for your listeners, if that's okay.
Okay, sure.
So my interest is in why the liver gets scarred, or liver fibrosis. This is a consequence of chronic liver injury from a variety of insults, and the most common around the world are hepatitis B, hepatitis C, alcohol excess, and increasingly something called nonalcoholic steatohepatitis or nonalcoholic fatty liver disease. And all of these illnesses are chronic smoldering inflammatory states of the liver, often with no symptoms. But during that time, there's progressive inflammation that stimulates scarring and ultimately can lead in a subset of patients to very advanced scarring of the liver known as cirrhosis. And so, I've been at this now since 1984, and in those days, it was hard to envision that we would make it to clinical therapies, but in fact, collectively, the field has uncovered a vast body of knowledge around how the liver scars, what the cells are that are involved, what are the signals, and from that has emerged the prospects of treating inflammation and scarring in the liver to prevent progression to cirrhosis. And one other consequence of advanced scarring or cirrhosis is the risk of liver cancer. And so we're highly aware of the long-term consequences of cirrhosis, not just being the loss of liver function and a lot of complications, but also heightening the risk year over year for the emergence of primary liver cancer or hepatocellular carcinoma. And so one of the prospects...
Quick question here. I've heard the liver is very regenerative, much more than pretty much any other organ, I guess, except skin. Are any of these conditions positively impacted by the liver's ability to regenerate, or does that is that overwhelmed by these conditions?
Mostly the latter, but I think the inherent regenerative capacity of the liver, which is far in excess of any other organ, explains why most patients with chronic liver disease have this, what I call smoldering disease, that's not even symptomatic for the bulk of their illness. Typically when patients have a chronic liver disease, it will progress to an advanced scarring state in 20, 30 years, sometimes shorter, but often that interval. Similar kinds of inflammatory diseases of the lung can progress to lung failure in the matter of 3 to 5 years. So I think what's happening in the liver that's unique is all the time when there's chronic inflammation, either from viruses or other causes, you have this compensatory regenerative response that's trying to restore the normal architecture in a way that's unique to liver. And that explains why some patients never progress to cirrhosis. In fact, probably most will never progress to cirrhosis. But even among those who do, it takes decades on average. And that's all a reflection of the fact that while that's going on, the liver is still exercising its regenerative capacity. We believe finally at the very end of decades, the liver's capacity to regenerate is ultimately exhausted. And that's really when scar simply takes over and drives the liver to fail or to generate hepatocellular carcinoma. So to return to your original question, knowing what we know now that we didn't know years ago, we can begin to envision therapies for scarring diseases of the liver, much as is being done in parallel for other organs like kidney and lung. In the case of liver, the main fibrotic or scarring disease that is targeted by pharmaceutical companies is the one called nonalcoholic steatohepatitis. And this is a disease of very rapidly rising proportions worldwide. It's really part of a full body syndrome known as the metabolic syndrome. So it's not just isolated liver problems, but rather the fat, inflammation, and scarring that occurs in these patients is part of a syndrome that includes typically type 2 diabetes, hypertension, obesity, hyperlipidemia. And in that context, there are a number of problems that arise. And often the liver is overlooked because physicians and patients are more concerned about blood pressure or lipid control. But in fact, these fatty liver disease patients need to be treated in some cases. And that's really where the focus is right now. So there are probably over 100 companies that are developing targeted therapeutics to stop either fat accumulation, inflammation, scarring, or all of the above. And there are... Go ahead.
A question about the liver itself. So I've heard it called NAFLD, right? Non-alcoholic fatty liver disease. Is the liver, does it have a lot of fibrosis? Is it scarred, or is it fatty, or is it both? And does it matter if it's one's more than the other?
Right. So it's a really good question, Richard. It depends on the stage. So in aggregate, patients who have fat in their liver, whether or not they have inflammation or scarring, are considered to have non-alcoholic fatty liver disease, or NAFLD. So that's an umbrella term. And within NAFLD, there are really three general stages. The first, and probably the most common, is fat alone. Fat alone in the liver is not a cause for concern, although some of those patients may ultimately develop inflammation and scarring. So that's simply called non-alcoholic fatty liver. The second term under the umbrella of NAFLD is NASH, non-alcoholic steatohepatitis. And the third would be cirrhosis. And so it's those patients in the second group, the patients who have non-alcoholic steatohepatitis, that are the ones who are being targeted for therapy because they have fat, they have inflammation, and they have scar.
So what are some of the correlations that have been discovered so far? Who tends to get fat in their liver and why? And then who tends to get NASH, and then who tends to end up in cirrhosis? Right.
So some of that we know and some of it we don't know. Those who tend to have fat in the liver are the ones that I mentioned that have the other risk factors: obesity, hyperlipidemia, hypertension, type 2 diabetes. There are some rare forms of fat in the liver, but if we restrict our discussion to the much more common, it would be patients with that profile have one or more of the features of the so-called metabolic syndrome. Now, what's interesting is we don't really have a good handle on why some patients only have fat, which never requires treatment for the liver, and other patients progress to NASH and beyond. There are clearly some genetic determinants, although not too many have been validated yet, that suggest that your genetic complement might put you at higher risk for getting the inflammation and fibrosis once you've developed the fat. Two of the more common ones, one is called PNPLA3, is a gene whose one of the variants is associated with fatty liver disease. And that risk variant is particularly common in Latinos who have a high allele frequency or a high gene frequency. And that gene frequency or that risk allele not only puts patients at high risk for disease when they have NASH, but also if they drink alcohol to excess. There's another gene that was discovered more recently called HSD17B13, whose function is not well known, but that's also, and then there are a couple of others, TM6SF2, MBOAT7. It doesn't matter what the names are, but in aggregate, the risk of progressing from just fat to a more advanced stage may in part depend on your genetic makeup. It may also depend on whether you have diabetes. So the presence among the clinical features of the metabolic syndrome, the one that more closely predicts risk of fibrosis is type 2 diabetes. So we tend to have an even higher level of concern for diabetics who have fat in the liver because they know they're at higher risk for also having that associated with scar.
So it appears that there's a lot more to diabetes, at least, than meets the eye. It involves the liver pretty strongly, and the liver gets fatty, and then Have you or other people looked at livers, from autopsies from patients, and looked, is the fat accumulated in a certain pattern, in a certain part of the liver, the top, the bottom, is it striped throughout? Is there any, is there any interesting structural components to the fat or the scarring?
The short answer is that the liver is fairly homogeneous in distribution of fat. At a microscopic level, it tends to be a little bit more towards the outflow of the vascular unit known as the centrizonal area of the sinusoid. But fundamentally, it's diffusely distributed. And we don't need to do autopsies to determine that. We do liver biopsies not infrequently, and that will certainly give us a good picture of the fat in the liver. But beyond that, there's now very good non-invasive methods that can quite accurately quantify the amount and also assess the distribution of fat in the liver. Those include MR spectroscopy and also something called MR fat fraction. So they're both MRI-based technologies. There's also a device that we use at the bedside in our practices or in the patients in the hospital that is called a CAP score, continuous attenuation parameter. And it's part of an evaluation that we do routinely along with something to assess liver stiffness known as a fibroscan. So we have a very good ability to detect and quantify fat in the liver using these imaging techniques. What we can't tell with them very easily is how much scarring and inflammation is associated with that fat.
So there's no way to correlate with the degree of fat, or does it have? I guess it's in bands. Does it? Does the liver look like a steak? Does the fat appear in a natural pattern? Does it appear in a very strange pattern?
The texture of the liver grossly to the eye, not just microscopically, looks very different. It looks fatty. Instead of being brown, it looks yellowy, glistening. And then if you do microscopic biopsies, you can see that the main cells in the liver, the hepatocytes, are stuffed with fat. So the fat is inside the cells of the liver, but it's so diffused throughout the organ that it makes the entire organ look more yellowish and fatty.
So, looking at it from a physiology perspective, does it affect, drainage of the liver? Does it slow processing time of alcohol or other foods?
Right.
Has anyone been able to somehow study, how does a fatty liver work versus a non-fatty liver? What's so different about it in its function?
Really good question. So for one thing, we know that fatty livers don't regenerate as well. And that has direct clinical implications because one of the miraculous things that our surgeons can do now is not just liver transplant from the deceased, but also what are called living-related donor transplants. So a healthy, ostensibly healthy donor can choose to give up a piece of his or her liver to a recipient whose liver is failing. Now, what we've been seeing is more and more when we screen those donors and make sure they have a healthy liver, it turns out that many of them have undetected or previously undetected fatty liver themselves. We know that kind of a liver is not suitable. First of all, it will not be as easy for the donor to tolerate the resection, but putting in a fatty liver into a recipient is a prescription for real problems. And one of the things also that surgeons will do routinely is assess the liver, any liver, whether whole or a part of a liver, for donation or transplantation. They will always assess at least visually to make sure that the liver is not fatty. A fatty liver not only will not regenerate, it also has a lot of fuel for inflammation. By that, I mean that fat can be broken down and release things called free radicals or reactive oxygen species that are very damaging to cell membranes and structures. And so, effectively putting a fatty liver in as a piece of donor liver is a prescription for real problems in terms of failing to regenerate and leading to injury of the tissue and often failure of that graft to survive through the transplantation. So that's probably the most obvious consequence of having a fatty liver. The other important component or risk associated with fatty liver is if you get a second disease or have a second insult to the liver. So, for example, if a patient has non-alcoholic fatty liver disease and then they start to drink heavily, or they get infected with hepatitis B or C, no question that 2 is worse than 1 and probably not even additive, but rather synergistic, so that fatty liver predisposes patients to having more severe injury if they're exposed to a second insult. Another one that's common besides those that I mentioned is in patients who might take Tylenol and take more than the prescribed amounts. Tylenol, as you may remember, can be very hepatotoxic or liver toxic, but it becomes even more toxic in the setting of a fatty liver. So that's probably a much more common risk than for patients who are undergoing transplantation or thinking of donating a piece of their liver. But for whatever reason, a fatty liver is not a healthy liver, even if there's not inflammation. And so we really want to, first of all, treat it if we can, and secondly, avoid having that patient develop a second problem in their liver that will be made much worse by the presence of fat.
Was there a degree of fattiness? Like, is there a Friedman scale of liver fattiness or something? You'd say you're 1 on 5 on the scale, or 1 out of 10, or 2 out of 10?
It tends to be semi-quantitative. It's certainly not named after me. I was far from the first person to study it. Yeah, I know. Maybe fibrosis, because that's what I've been studying for the last 35 years. But generally, there are different ways to quantify it. You can quantify it as, and the most common is to say what percentage of the liver is fat. And you can do that using one of those imaging tests, particularly MR fat fraction. You can literally say 30% of the liver is fat, 20% is fat, and those tend to be very reliable. And we use those often as benchmarks if we're trying to reduce the fat with a treatment. So we'll say the patient started with 20% liver fat, and now they're down to 10%, and they had a 50% reduction in liver fat. Those are the kinds of things that we're beginning to lean on as we try to assess whether drugs are having any impact on disease.
Yeah, so if someone has, when do you tend to find, when does someone, since it's asymptomatic, at what point are people told they have a fatty liver? And again, are there at least 3 levels, like severe, moderate, mild, and what percentages might correlate with those levels, if there are any?
The levels of fat per se don't necessarily tell us whether they're likely to have less or more inflammation. The typical way that patients come to a particular liver specialist is one of 2 ways. Number one is they have an ultrasound for another reason. They might have belly pain, or there's suspicion of gallstone, or whatever. An abdominal ultrasound is obtained, and inadvertently the radiologist will tell the physician and the patient, hey, there's quite a bit of fat in that liver. The other way that patients can be diagnosed or at least detected is they go for routine blood work, and one of their liver tests is slightly abnormal. And those are never cause for alarm, but they are cause for follow-up and possible further evaluation, because typically the liver tests that we see in patients who have inflammation and fibrosis as well as fat, those liver tests are not wildly abnormal. They're typically 2 or 3 times normal. So normal can be up to, depending on the lab, it can be up to 30, and it may be 90, it may be 100. Nobody gets alarmed by that. On the other hand, it is a tip-off that there may be something going on, and that will merit further evaluation. Now, the problem is that there are also patients who have a lot of fat and inflammation who have normal liver tests, and so we can't very well advocate for doing liver tests as a good screening test and saying that if they have normal liver tests, there's no way they have fat. That can't be said, because, in fact, there are ample numbers of patients who simply don't have elevated liver tests that will be a clue that there might be underlying liver disease.
So the drugs that are being developed, what's the goal? What are their metrics? To keep fat at the same level over years, or to reduce it by a certain percent?
Right. The overwhelmingly most important determinant of whether patients will get into trouble is how much scarring they have. So that's been done in study after study. While fat can be a tip-off that there's more going on, per se, fat alone does not predict outcome. On the other hand, if you do a liver biopsy, as we do in many patients, the amount of scarring they have is a direct predictor of how likely they are to get into trouble. And so directly or indirectly, all the treatments that are being developed are with the intention to ultimately reduce the deposition of scar, or in some cases, when the scar is already very advanced, to enhance the degradation or removal of that scar so the liver can either restore or preserve normal function. So it's really, in simple terms, it's all about the fibrosis. And so one doesn't have to attack the fibrosis directly, although that's something I'm very interested in through my own work. One can try to reduce fat and inflammation with the expectation that that will translate into a reduced drive to make more scar. And that in part may be one of the ways that a drug that's being evaluated now or in the next couple of months by the FDA may actually exert its benefits. So there's a drug called obeticholic acid. It was developed by Intercept Pharmaceuticals. Full disclosure, I've worked with Intercept as a consultant off and on over the years. We actually did initial studies in my laboratory over 15 years ago when they were barely a company. And we showed that the agent in an animal model, a rodent model of scarring, seemed to be very potent. And that led to the company filing what's called an investigational new drug application to the FDA and a 15-year course, which I wasn't really involved with, where the company sought and ultimately were able to prove in a placebo-controlled trial that the drug has more effect than a placebo in reducing scarring and inflammation. And so that's probably going to be the first drug approved. Nobody knows for sure. I certainly don't. But it's going before an FDA advisory committee in late spring to assess whether they have enough data of efficacy to grant the company the approval to market this drug. So that will be, if it happens, that will be the first. There's at least 2 other drugs that are in so-called phase 3 trials, which is the most advanced level of study before a drug can be approved. But there are dozens and dozens of drugs still in phase 1 and phase 2 that promise to have even more potency than obeticholic acid. Although in the end, it'll be up to the clinical trials to establish their efficacy and the relative potency compared to obeticholic acid. By the way, obeticholic acid is a very interesting class of molecules. It's an agonist to a specialized type of receptor in the nucleus. The receptor is called farnesoid X receptor, or it's abbreviated FXR. And the drug obeticholic acid is an FXR agonist. So in other words, it enters the cell, it tickles that receptor, and the events downstream of that receptor being activated are beneficial in preventing or eliminating the stimulus for inflammation and scar.
Does anyone, when you look at a healthy liver, does it have any fat in it or just a little bit? And does anyone understand the mechanism by which, hepatocytes or other liver cells would start to accumulate fat?
So to answer your first question, normal liver should not have fat. I mean, there might be a rare droplet, but, basically a normal liver has no fat. But fat can come and go inside the liver very quickly. It's been well shown years ago in experimental studies that if you recruit, in those days, medical students to drink an alcohol binge, and then they agreed to a liver biopsy the next morning, they would have fat as a result of that binge. And fat can come from the liver from one of 2 ways. Either the liver makes more fat or the liver acquires more fat through the diet or through circulating lipids that are brought into the liver more than they are leaving. And so what we can say is that the fat in the liver is a very dynamic response, and it can change in a matter of hours. One interesting and recent circumstance where that turns out to be very helpful is if we return back to the example I gave you of fatty livers being less attractive to use as a donor organ for transplant, there's now actually several technologies, one in particular from Europe that's been written up in the journal Nature. But there are several technologies that say, okay, if we harvest a liver that we intended to use for transplant, but it's got too much fat, we don't want to throw it out. So what they're doing is they're putting the donor liver, the future donor liver, on a pump. They're perfusing it with nutrients, and they're effectively, in other things, they're adding more energy substrate, and they're also defatting the liver. So it's well known that in a situation like that, you can defat a liver in a matter of hours, which really underscores the point that I'm trying to make, which is fat can come and go very, very quickly, but normal liver should not have fat.
You can defat a liver in hours? Like what percentage?
Most of it. I couldn't give you an exact number, but the majority of the fat can be removed in a matter of hours if you create conditions for perfusion that lead to the egress of fat from the liver into the perfusate.
It's too bad you couldn't sedate someone and run their blood through a filter and defat their liver, in some kind of clinical application.
Yes, it's true. We don't use it in that setting. Occasionally, there are a number of different devices that have been tried over the years. None of them are FDA approved, and they tend to be more popular in Europe and Asia. But in patients who have toxin buildup because their liver is failing, there have been efforts in a number of different what are called liver assist devices that can effectively cleanse the blood, much like dialysis does for kidney failure. The primary goal of those liver assist devices, however, is not to clear fat, but rather to clear many of the toxic metabolites that ordinarily the liver would break down and excrete. But in the absence of good liver function, you need the machine to do that.
Yeah, because the liver breaks down a lot of substances, metabolizes them. Do substances tend to have a longer residence time in the liver than maybe other organs, or a long enough residence time that they're more effective, or they more strongly affect the liver? And does that bear anything on the drugs that are being developed?
Yeah, it's a very perceptive question, Richard, because when we think about developing drugs that are intended to treat liver disease, one of the arguments that we make, particularly for drugs that are broken down in the liver and we don't want them to get to the other organs as much, as we'll say, look, if we give this oral agent, it's taken up by the intestinal cells, it's transported to the liver, it exerts its function within the liver, but it's also degraded. So the amount of drug residual that goes out to the rest of the body is much smaller. And often that creates an opportunity to target drugs to the liver without worrying about the effect of those drugs nearly as much on the organs that are elsewhere, kidneys, lung, heart, etc. So we know, and that's called first-pass metabolism. So the liver, our livers evolved this unbelievably complex and orchestrated system for detoxifying things that we put in our mouth that are absorbed. And this, of course, isn't restricted to the era when man has drugs. If you think about it, as our ancestors thousands and thousands of years ago roamed the earth, they picked up a berry and ate it, and there was a toxin in that berry. They either might die from that, or they might evolve systems or be advantaged if they have complex systems to detoxify that berry. Fast forward 10,000 years, and those berries are now medications. And so particularly for medications that are novel molecular structures and not just natural products, the liver really has to depend on this complex system of detoxification to make sure that those drugs don't either damage the liver or damage the rest of the body.
Does the liver, it detoxifies, I guess, by breaking down a chemical into other ones, but does it detoxify by storing? Does it, what other ways can it detoxify?
That's a good question. It can be detoxify in a number of different ways. It can convert to an inactive metabolite that is then excreted by the liver into the bile, and often those can be, converting from what are called lipophilic to lipophobic, or compounds that are more water soluble. So one of the major detoxifying mechanisms of the liver is to change the chemistry of the compounds so that they're more easily excreted in the bile. There can also be chemical reactions that will specifically remove toxic components of a drug or a substance, or it can occasionally store things that, if they're in excess in the body, can cause damage. And the most obvious example is cholesterol. So in principle, the liver can store cholesterol, often in the form of these fat droplets. In some ways, if the fat never gets out of the liver, it has less opportunity to contribute to atherosclerosis. There are also circumstances where the liver will store toxins like excess metals like iron and copper, which up to an extent the liver can absorb. But it turns out that if you store too much iron and copper, that can lead to diseases primarily of the liver.
Has a fatty liver ever been transplanted from one mouse to another, even apart? And I guess based on the recipient mouse's diet, have you seen effects? Does that rejuvenate the liver, or even just in a person? Does diet seem to affect the liver tremendously, or no?
So let me tackle that one first, which is that diet absolutely can affect the liver. In the most extreme ways, diet that includes toxins can damage the liver severely. I already mentioned Tylenol or acetaminophen, but it turns out there are some natural substrates that are very toxic. The most well-known is a particular type of mushroom called the Amanita mushroom. So it turns out those mushrooms have a poison in them that paralyzes the intracellular machinery of the liver cells. And over the years, there's occasionally misadventures where a family or a group of people go mushrooming, they're not expert, they eat these mushrooms and they all end up having liver failure, and some actually require liver transplants. So certainly diet in that way, in an extreme way, can affect the liver, but diet can also affect the liver in terms of, having adequate protein and adequate minerals and vitamins that are part of a normal, healthy, well-balanced diet. And there are, of course, deficiencies that can affect the liver as well as other organs. Most of the essential vitamins can affect the liver, and in general, excess dietary fat ingestion will lead to fat accumulation in the liver. So the diet has a range of potential effects on normal, healthy liver function, or it can lead to liver disease.
Well, early on when you mentioned if someone needs to donate a piece of their liver to a family member or a matched donor, or matched recipient, it's not good if they have a fatty liver. And then you mentioned that sometimes it can be, it can be cleaned out. But, has anyone ever tried, let's say in mice, taking a piece of one mouse's liver that was fatty, put it into another mouse and, see what happens? And does the new mouse, the recipient, defat the liver, or does it, what happens?
No. Yeah. So you probably, I don't know the answer, but I would make an educated guess that if you took a fatty liver in one mouse and you put it into a genetically identical recipient mouse, that it wouldn't function it might function. It wouldn't function as well if that donor liver had been normal. And just to clarify one point, defatting of the liver that I mentioned is being done for what are called cadaveric liver donations. It's not being done for those living-related donor segments. Rather, if a potential donor wants to give his or her piece of the liver, typically to a family member, if they have fat, they're just not accepted as a donor. One would never resect a fatty piece of liver from a donor and then try to defat it before putting it into a recipient. That wouldn't happen. You just wouldn't do the transplantation in that setting.
Yeah, it's too bad that it couldn't happen. Maybe that, but that.
And it may yet. One of the things that, which is done in terms of defatting the liver to allow that kind of transplant is, patients who might be overweight and want to donate, but they have fat, are put on, very rigorous medically supervised diets to lose weight and thereby lose liver fat. And then they become suitable donors. That's a much more sensible way of defatting the donor liver, not to take it out of an overweight person and try to take the fat out using a machine. Yeah,
it makes sense.
Right.
What's this doing to the transplant space if fatty liver is on the rise and, it seems like obesity is, that seems like it would shrink the available donation space for liver transfers too.
Yeah, absolutely. And that's exactly why these technologies are being developed to try to rescue or restore fatty livers, because the donor pool of healthy livers is going to shrink as more and more of us walk around with too much fat in our livers. But on the flip side, the fat and the inflammation in the liver and the presence of this NASH is becoming so prevalent now that it is probably or will soon be the leading cause or leading indication for liver transplant around the world. It certainly is close to that, but there's an underside that's a happy ending to explain why NASH and probably alcoholic liver disease are becoming the most common indications for transplant. And the happy part of that is, in part, it's because the transplants that were necessary for patients with hepatitis C are shrinking in number tremendously because we have curative therapies for hepatitis C that promise to eliminate the virus in over 95% of patients. And what's amazing is when you have a patient even with cirrhosis who has hepatitis C, when you cure that patient effectively with the newer antivirals, a sizable fraction of them get regeneration of the liver and the scar can recede. So for all those reasons, NASH and alcoholic liver disease is becoming the two most common indications for liver transplant, primarily because their prevalence is going up, but also because the prevalence of advanced liver disease from the other viral causes is going down.
Oh, okay. Well, at least it's not all a net negative. That's good.
Yeah, I think that's right. No question. The number of transplants for Hep C has gone down precipitously in the last 5 years.
So what's the near-term future in the next 5 years? You said a lot of drugs are in clinical trials. I mean, when do you think clinically people are going to have a lot more options available to them, maybe, to help with fatty liver and other liver problems?
As I said, most of the energy is being focused on fatty liver disease, and with one drug approval more likely than not, and several right behind it, I think the next 5 years we're going to completely redefine not only how to treat this disease, but also to refine how to diagnose it. The so-called gold standard for diagnosis currently is liver biopsy, but that's an invasive test. It can be very informative, and we do quite a bit of it, quite a number of liver biopsies in our center. But still, we'd like to be able to capture as much information about the liver without biopsy as possible. So there are imaging techniques, there are biochemical techniques. There's lots of different approaches that are slowly but surely making headway in our ability to diagnose the stage and the severity of liver disease without having to do liver biopsy. And that's a really critical building block to accelerating clinical trials, because we'd like to know as quickly as possible if a drug looks like it's having a benefit without having to wait for the biopsy. And the more we get tests, non-invasive tests that can tell us quickly whether a patient is showing benefit from a drug, the quicker we can get those drugs evaluated in large groups and ultimately brought to market if they're safe and effective. Okay. So I think the next 5 years in aggregate is going to see steady, incremental improvements, some failures along the way, no doubt, but we're past the point of no return. We know that this disease can be improved. Now we need to get to the point where we can improve it in a larger fraction of patients and more quickly.
Very good. All right, Scott, what's the best way for people to find out more? If they suspect they have a problem, they should go to their, general practitioner and go from there. But if they want to learn more, then what?
So there are a couple of professional associations. The American Liver Foundation is a great resource. It's really patient-directed, and they have lots of information. Our Mount Sinai website has quite a bit as well in the liver division. And the AASLD, the American Association for the Study of Liver Diseases, has a very informative website. And those are three good places to start. Most institutions have some information on their web pages as well. And there are other professional associations and patient-based associations that are also beginning to develop information on their websites as well. There's something called the Fatty Liver Foundation. That's a patient-run organization that also has quite a bit of information. So more and more ways to get information. Certainly, it's always prudent to start with your doctor and let them make an assessment of whether you have fatty liver and what additional studies are appropriate. But certainly, all patients want to read more, and Google is a handy way to get started. But I would direct them directly to the ALF, the Fatty Liver Foundation, the AASLD, the Mount Sinai website, and other reputable websites. I would not encourage websites that promote natural and herbal treatments. Those can be very dangerous, or commercial websites from companies that are trying to sell supplements. They should stick to reputable websites that are, by well-respected professional organizations.
Yeah, makes sense. Okay. Well, very good. Well, Scott, thanks for taking the time, and I appreciate you coming.
Pleasure to be here. Best of luck to you and your listeners.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.